Hi guys, this is Alicia with Good Morning Sunshine. It is now it's still week 7. What's today? Is today Wednesday? I don't even know. I always lose track of my days. But it would be 26, 27, 28, day 28 of vet school. If I did the math correctly, I don't know. Math hasn't been my strong suit lately, and we have to learn drugs and doses and all of that, so that's gonna be really fun. But I have a long day tomorrow. I'm there 8 to 5 tomorrow. We also have a quiz on top of that, and then an exam on Monday. It's just a lot of stuff. But yeah, so we did pharmacokinetics again today, and then we did more endocrine, and then we ended up with birds. I was excited about the bird lecture, but it was Dr. Bonnie's last lecture until January, and I'm really sad because I really like her. You guys already know that. I talk about her every time I have her. But she dresses so nicely, too. She was like in a little blouse today and her little black pants because she's small, you know, like me. But she's like the cutest thing. But anyways, I'm going to start with pharmacokinetics. So where were we? Where did we take off? We've learned that drug has been delivered from its dose form to the plasma. The drug has been delivered from the plasma to the site of action, and then drug still needs to be metabolized and excreted. So the pharmacokinetics we learned today was drug metabolism and elimination. So again, we have the ADME, A being absorption, D being distribution, M being metabolism, and E being elimination. So we're at the very end. We're at the metabolism and elimination spot. So again, a prodrug, just to throw the definition out there again, because we're going to be using it in today's topic. A prodrug is used to improve how a drug is absorbed. It is just how it is absorbed, distributed, metabolized, and excreted. They are metabolized into a pharmacologically active drug. So the objectives of today's lectures was to understand how organs involved in factors affecting drug metabolism, and to understand phase 1 and phase 2 of drug metabolism, to understand the concept of drug clearance, and lastly the mechanisms of renal drug clearance. So metabolism, also known as biotransformation, it's converting a drug from lipid-soluble active drug to the soluble inactive drug. So purpose in general is to convert lipid soluble, just like I said, active drug into water soluble inactive drugs. So it's ready for elimination. Exceptions of this is prodrugs, like I just gave you the definition of, are the exception. I cannot talk today. So inactive to active. And water-soluble drugs may not need to be metabolized, because if the drug is water-soluble enough, it does not need to be metabolized. This is accomplished with enzymes, so cytochrome P450s and others. So then we got into the function of the liver. The main function of the liver is to detoxify. Although there are other organs involved in drug metabolism, the liver is definitely the most important. And I also forgot to shut my door. So the dogs keep barking. The liver and drug metabolism, phase 1 reactions, is oxidation, reduction, and hydrolysis. It makes drugs more polar and is performed by the CYP 450 enzymes. And then we have phase 2 reactions, which has to do with conjugation, has to do with glucuronidation, acylation, methylation, and sulfation. So I'm going to show you a diagram here, which basically goes over everything I just told you. So this is phase 1. On this side, we have oxidation, reduction, and hydrolysis, like I told you, and the enzymes that is used is the cytochrome P450. And then phase 2 has to do with the conjugation with polar group, and all those I just said, I'm not going to say them again because those are really hard to say, and they use transferases. So the lipophilic drug and chemicals go to drug metabolism. which then go to water-soluble metabolite and then excretion into urine bile. So phase 1 metabolism, we're going to get more in depth to that, are non-selective enzymes. The major source of variability in drug metabolism is within and between species. The enzymes are located in the liver mostly, but they can be located in other tissues like the gastrointestinal tract and the skin and the kidneys. And it includes induction and inhibition. So what does this mean clinically? Well, we co-administer 2 drugs that might interact and get metabolized together. So then it was said, so people think we're more closely related to dogs, so they usually test drugs on dogs before they put them out on people, which is crazy. Because apparently we're more closely related to pigs, and we should be testing our drugs on pigs and not dogs. So drug metabolism has inhibitors, which include ketoconazole, fluoxetine, omeprazole, and cimetidine. And then we have inducer drugs, which is inside our body, which are phenobarbital, rifampin, and glucocorticoids. So inhibitors, this also includes the CYP450 inhibitors, which may also inhibit P-glycoproteins. And then inducers, their overall effect is to decrease concentrations of other drugs that are substrates of the CYP450 enzyme. So then we got into pharmacogenomics. So what is the consequence of being an ultra-fast metabolizer? What is the consequence of being a slow metabolizer? And how does this change with a drug that has an active metabolite? And what if the metabolite is more toxic than the parent drug? Well, ultra-fast metabolizers will clear drug more rapidly and therefore are subject to treatment failure due to low plasma concentrations. Slow metabolizers will clear drug more slowly and therefore are subject to toxicity due to the high plasma drug concentrations, unless, however, it is the metabolite that is active or toxic. For drugs with an active metabolite, ultra-fast metabolizers may have a better and more rapid therapeutic response compared to normal or slow metabolizers. However, if the metabolite is more toxic, they may also be susceptible to more drug toxicity. So getting more into phase 2 metabolism, UDP, which means glucuronidase transferases. It's a big word to say. But anyways, these are all really big to say. We have sulfosyltransferases and acetyltransferases, glutathione S transferases, and thiopurine S methyl transferase. So there's species-specific differences. Cats, glucuronidation, not on test. I put that. And then she didn't even know what that meant. So yeah, that's definitely not going to be on our test. And then we have sulfation. So basically that's meaning Tylenol kills cats. So do not give your cats Tylenol, please. And then dogs, acetylation is slow. And then in pigs, sulfation is, it's not great at that. Factors affecting metabolism is age, decreased drug metabolism in young, because the liver hasn't matured yet, and very old, and we might run out of metabolizing enzymes. Gender, they're not sure if that is a factor that affects metabolism. There's not much study done on that. Disease, we have hepatic disease. Genetics, again, they're not sure. And species and breed, the greyhound, they know, responds differently to drugs. And then enzyme saturation, so zero order, which we'll get into later. So then we got into the pharmacokinetics of metabolism and elimination. Drug clearance, that's one of the objectives, is the hepatic metabolism and renal elimination. Definition of this is volume of blood cleared by a substance per unit time. So it's reported in milliliters per kilogram per minute. It reflects rate of drug elimination from the body. Again, both metabolism and elimination. and it encompasses all organs capable of eliminating drugs. But note, there is no one pharmacokinetic parameter associated with metabolism. If a drug has an active or toxic metabolite, it must be measured in the blood to determine its rate of formation, its maximum concentration, and etc. Hepatic clearance is dependent on the blood flow to the liver and the intrinsic metabolizing capacity for the drug. So hepatic blood flow times the amount of drug extracted by the liver equals the extraction ratio. So there's two types. There's perfusion, which means flow. It also means limited drugs. The high hepatic extraction ratio drugs, the liver has a ton of metabolizing enzymes, so blood flow is the limiting step. High concentration of metabolizing enzymes, again, in the liver. Liver can metabolize as fast as the blood can deliver. So free drug only, plasma protein binding can be rate limiting, and it's linear or first order kinetics. The capacity limited drugs are fewer metabolizing enzymes in the liver. Low extraction ratio drugs. Liver has low capacity for metabolism due to the low concentration of metabolizing enzymes. Blood delivers faster than the liver can metabolize, so more free drug in liver, so it's too much for the liver to handle. Protein binding does not limit, as free drug concentration exceed metabolizing capacity, zero order or non-linear kinetics. So then we have drug excretion, so irreversible elimination of drug from the body, unchanged metabolites, and then elimination by metabolism. The liver chews it up and spits it out, thus renal elimination doesn't come into play because the kidneys have nothing to metabolize. But major routes are the kidneys, the bile, also the gastrointestinal tract, and then feces let out lipophilic drugs. Other routes of excretion but aren't as important, they're very minor, are milk, lungs, saliva, and sweat. But for renal elimination, there's three major mechanisms, which are filtration, tubular secretion, tubular reabsorption. And then we have glomerular filtration, which is mainly passive diffusion to the urine. It's a major way to get drugs out of the body. For small molecules, protein unbound molecules, and things like that. But then we have tubular secretion, which is with the proximal tubule. It has active ATP for energy. It has a carrier mediated. It's saturable. It's in competition. And then we also have tubular reabsorption in the distal tubule. These are for lipid-soluble drugs, unionized drugs, and ion trapping, which we talked about. So again, ion trapping is like unionized and like. So again, unionized drugs go to the urine. So acids go from the blood to the urine due to it being more acidic. However, a weak acid excreted into more acidic urine will become mainly unionized and therefore can be reabsorbed back into the blood. However, bases go from the blood to the urine, but a weak base excreted into a more acidic urine will become mainly ionized and therefore less is reabsorbed by the blood. So why is this important? Well, therapeutic role in drug overdose and toxicity. We have pentobarbital, which is a weak acid. And here we go. So ionized drugs and ion trapping for pentobarbital, again being a weak acid, non-ionized. It is non-ionized in the acidic pH of the urine and available for reabsorption. So it makes urine more alkaline. And sodium bicarbonate to promote excretion. Then we have fluid administration, species differences. Herbivores have alkaline urine, basic drugs more likely to be reabsorbed. Example, gentamicin. It's very difficult to make their urine acidic for horses. Unless you run the horse for a very, very long time at full speed. And then we have factors affecting renal elimination, like renal disease. Its consequences higher toxic plasma drug concentrations and prolonged drug effects. Example would be ketamine anesthesia in a blocked cat. So we make dose adjustments to reduce dose or extend dosing interval. Then we have biliary elimination, which is a secretory process, fairly nonspecific, and it's polar for large molecular weight compounds, and it's free drug only. And then we have enterohepatic recirculation, where drug is absorbed and enters the liver. A fraction of drug is conjugated and excreted into the gallbladder. Drug is excreted into small intestines, where the gallbladder contracts after a meal. Microbes in the small intestine are unconjugated drug, and drug is absorbed and enters the liver. So unconjugated drug reaches the plasma. So why after a meal? This is because the gallbladder secretes a lot of bile, and then it helps with food digestion. And then not all species have a gallbladder, so horses and rats do not. But may still have secondary absorption peak in the plasma, so that's due to formulation factors, colon absorption, feeding factors, and urine reabsorption. And then we got into the clinical relevance of clearance. The calculation, the constant rate infusions and rate of infusion. And then we have elimination half-life. But we didn't really go into that. She missed a few slides. So the last few, I actually don't think we talked about much. She has to continue her lecture because she has another one tomorrow. There's 16 questions on our exam about pharmacokinetics. But then we got into endocrine. Yay. We're talking about the pituitary. So there's a posterior pituitary and a anterior pituitary. So the pituitary, I've been saying that wrong the whole time, is at the base of the skull. And again, there are two. They're in the same place, but mainly independent from each other. So the posterior pituitary has the pars nervosa. It has cell bodies in the hypothalamus, and axons go to the posterior pituitary. And the hormones that are released from here are oxytocin and vasopressin. So oxytocin deals with milk letdown. It deals with smooth muscle contraction at parturition, so it pushes the baby out. And maternal behavior and bonding, so the mother releases more oxytocin when she hears her baby. So in a C-section, they would actually lose oxytocin release. They would miss out on this step, so they may have to give this drug. And then we have vasopressin, which is an antidiuretic hormone. It reclaims water from urine to increase blood volume. It constricts arterioles to decrease functional blood volume and therefore increase blood pressure because less volume requires less fluid to fill it up. And then moderate behavioral effects similar to oxytocin, and then absent leads to diabetes insipidus, which means too much urine, and it's not sweet urine. And then we have the anterior pituitary, which is glandular and not part of the nervous system. It is complicated embryologic origin, therefore things can go wrong. And then several distinct cell types, each a specialist for one hormone. So we have the growth hormone, which deals with negative feedback from somatomedin. So when somatomedin goes up, growth hormone goes down. So the growth hormone stimulates the growth of bones, so the length, if the epiphyses is not closed, and then width if the epiphyses are closed. Also gluconeogenic, making too much of new glucose, so moderate but persistent, which could lead to hyperglycemia, which will exhaust the pancreas of insulin. Deficiency can result in dwarfism, usually complicated with other syndromes due to loss of other hormones. And then we have hypersecretion before maturity, which can lead to gigantism, which is very rare, but still there. And then it can lead to hypersecretion after maturity, which in turn is acromegaly, which means the distal limbs are too big or thick. This usually happens in cats, and usually if you have this, the cat is also usually diabetic. And then we have the thyroid stimulating hormone, which they are lipophilic but also hydrophobic. This hormone stimulates growth and activity of the thyroid follicular cells. The follicular cells make mostly T4, which I'm sure you heard of, and also T3. T4 is placed into the colloid, which is a protein matrix in the lumen, into follicular lumen attached to the thyroglobulin, which is high affinity and high specificity. When needed, it is absorbed, split from the thyroglobulin, and secreted into the bloodstream. And then thyroid, more about thyroid. T4 is the main product, but metabolized to T3 by the kidney and liver. T4 and T3 are both metabolically active. T3 and T4 interact with receptors in the nucleus, not on the cell surface, and they mimic steroid hormones. Several actions to increase metabolism. They increase oxygen uptake and use and enhance heat production. They increase glucose absorption from the gut and enhance movement of glucose into the cells, partly by insulin, and they must facilitate growth along with the growth hormone. They enhance lipolysis and can lead to hypercholesterolemia. This is screw up in fat metabolism, and they can enhance neural function and cardiac function. So there's thyroid disorders. There can be the overstimulation of the TSH due to iodide deficiency or poisoning of enzymes. And then T3 and T4 cannot be made. And then we have hypersecretion from hyperplastic lesions in cats. Autonomous secretions, so increase in T3 and T4. So the thyroid is basically stuck on, which means secreting too much of the hormone. And this is a decrease in the TSH. And then we have hypofunction, which is too little thyroid, which is common in dogs with various causes. And then we got into adrenal glands. So each adrenal is really two independent glands, which includes the cortex and the medulla, which we've talked about before. The cortex comes from the mesodermal coelomic epithelium, and it produces steroid hormones, whereas the medulla comes from, and the dogs are barking again. I don't think they ever stop barking. Hey! Hush! So then we have the medulla. Sorry about that. And it comes from the neuroectoderm, which produces vasoactive catecholamines. So getting into the adrenal cortex, there are 4 concentric zones. Each produce different hormones from outer to inner. So we have the zona glomerulosa, which produces mineral corticoids. It's not pituitary dependent. It maintains ions in narrow ranges. Then we have the zona fasciculata, which produces glucocorticoids, and it is pituitary dependent, like ACTH. And then we have zona reticularis, which produces glucocorticoids and sex steroids, and it is pituitary dependent. And then we have a temporary fetal zone, which helps with estrogen production during pregnancy and soon after parturition, and it regresses after postpartum. Steroid hormones are all interrelated. Production depends on specific enzymes that are localized to specific cells, and some overlap of function. So glucocorticoids includes cortisol and corticosterone, which are transported with proteins in the blood, both specifically and non-specifically. They bind to receptors in the cytosol and then go to the nucleus and affect transcription. They do with metabolism, especially glucose metabolism. They suppress inflammation. Cortisol is mainly metabolic. Corticosterone is mainly anti-inflammatory. They each overlapped and also overlap with the mineral corticoids. They're highest in the day and lowest at night. Synthetic mimics are common as therapeutic drugs, mainly for anti-inflammatory properties. And then we have the metabolic. What it does metabolically. Sky, stop! And then what it does metabolically, we have gluconeogenesis, lipolysis, protein catabolism. It basically uses proteins as an energy source, and then we have increased water excretion. And then inflammatory, decreased in general, and it suppresses immunity. So feedback, we have overproduction of glucocorticoids. We have ACTH, which stimulates the production of the glucocorticoids, and then glucocorticoids inhibit ACTH secretion, and chronic stress is a major stimulation. So this has to do with the overproduction of glucocorticoids. And then we have therapeutics, which their main use is anti-inflammatory. The pathways to upregulate or downregulate are slow and delicate. Exogenous products work quickly, and once removed, the body responds slowly. Taper exogenous sources slowly. So then we got into mineral corticoids. Aldosterone is the main one. It affects distal renal tubules, also salivary glands and the sweat glands. It moves sodium from cell to the interstitium, and water follows this. This loses potassium and hydrogen, so metabolic alkalosis is a possibility, which means so too much of mineral corticoids leads to this. And then aldosterone, renin is an enzyme from the kidney upregulated by a decrease in blood pressure. So renin activates angiotensinogen, that's hard to say, to angiotensin 1, which goes to angiotensin 2, which angiotensin 2 stimulates aldosterone production. It's also used as a secondary control mechanism to downregulate renin release. So high sodium downregulates renin release, whereas high potassium can stimulate aldosterone secretion directly. So mineral balance, many factors interact for this. Electrolytes are essential for fluid homeostasis as well as cell functions. Control mechanisms can also spiral out of control when there is heart failure. So a decreased heart function, there's a decreased blood pressure. This is all that the renin can see, basically. This whole system can actually see, and it again responds to it, but doesn't actually see that the heart's failing, if that makes sense. So they increase blood volume, so there's an increase in renin, an increase in the angiotensin 2, and an increase in the aldosterone. So this leads to an increase in fluid retention, which further overloading heart, which it cannot raise blood pressure. So this is further stimulating the renin. So correcting it. So their job, they're trying to correct for something, but they don't know that the heart's failing, which is leading to the heart continuing to fail. Then we have melanocyte stimulating hormone, which we don't need to know this, so I'm not going to go into it. And then he was just letting us know that our body can mess up at so many different levels. We can block a receptor, we can have an inactive receptor, we can stick receptor and get it stuck in the on position, we can fiddle with internal processes. There's a lot of things that can go wrong. And that was the end of the endocrine lecture today. And then we got into bird stuff, which I actually like bird stuff, so I can show you things. So skin of birds is much thinner than in mammals. It is loosely attached to underlying structures, except on the face and the distal pelvic limbs. You can see the veins because the skin is so thin. And then they have different feathers here. So we have the tail feathers, the flight feathers, the semi-plume, the phyloplume, and then the bursal and the downy. So flight, tail, and wing have the most intricate patterns for their feathers. They are primary and secondary feathers of the wing, and they are tail feathers. And then they have contour feathers, which is most of what you see when you actually look at a bird. So they're smoothing the external surface of their bodies, and they streamline the body for flight. So basically, all the feathers you see are their contour feathers. And then their down feathers are what keeps them warm. They're specialized, they're fluffy, and they're on the skin, and they're used for insulation. And then they have bristle feathers, which are very tactile. So when insects hit them, the bird just snatches it right up. So the bristles are on their beak right there, if you can see them. And then they are featherless on the face, which are, their face is pigmented in some species and tight to the bone beneath. Some birds have a cere, which is a soft, sometimes fleshy elaboration surrounding the nostrils in some species. So that's a cere right there, where it's pointing to. But then some don't have a cere. And then they have beaks, which are different dependent on what the beak is used for. And then they have spurs, which most people think of spurs as their like fifth toe. I don't know. But this is not true. It is not a toe. It is used in defending territory. It is supported by bone. The spur is long, but inside there is a core of bone. They use it to spur other chickens or when they feel threatened, and they even spur us sometimes. And then on their feet, they also have scales right there. Oh, their spur is also that little thing on the side. And then they have the uripitial, which is also known as a pre or the oil gland. Only some species of birds have this. The oil assists in maintenance for feather shape, luster, and water repellency. However, it's the structure of the feather that makes them waterproof. It's not this oil. And then we got into the skeletal system of a bird. It is tremendously lightened. True in all species of birds through moroso, and those who fly more than others who don't. So diving birds, loons, and penguins. So a general feature, they have cortices of avian longbones are very thin and easily fractured. Most of their bones are fused together. This is to lighten them up. There's no free tarsal bones. The tail caudal vertebrae are fused. The coracoid bone, well developed and necessary for flight. They also have a clavicle, if you know the wishbone, that's also fused. And then their manus, which means their hands are highly specialized. They reduce the number of digits and the number of bones, and they are attached by ligaments. And then we got into the muscular system of birds. Most major muscle groups of mammals are present and accounted for. Of the vertebral column, the flexor and extensors of the limbs. The epaxillary and hypaxillary muscles greatly reduced in the thoracic lumbar area, except in the neck. So there's much fusion among many vertebrae in the post-cervical vertebrae column because they render them unnecessary. And then the pectoral muscles of a bird are hardly modified for flight. So the ones here, those are your chicken breasts, and those are your chicken tenders. However, superficial are the huge ones here, and the deep ones are those little chicken tenders underneath. And then we got into the respiratory system. They have infraorbital sinuses, which is important. They're large and communicate with the nasal passages. And then we have to know when a bird has sinusitis, where they're swelling around their eye. Then they have nostrils and nares. So we want to recall may or may not be ornamented by the cere. Remember the hair, that's by their nostrils. And then we have the trachea. They're unique. Their rings are complete. They don't have a trachealis muscle here and can sustain large airflow. They have a syrinx, which is the source of vocal sounds. It's positioned at the division of the trachea into their primary bronchi. The bronchi divide repeatedly into multiple smaller, tiny, microscopic airways called air capillaries, which is one huge difference. There's no dead end alveoli. Yeah, so I'll show you this. They have air sacs. They do not have lungs. No lungs. Just kidding. They have lungs, but they're very tiny, so that was joking. But they do have air sacs. So the lungs are not used for gas exchange. They're small and they don't expand like ours. So they have lungs, but they don't expand. So they use the air sacs instead. So those are expanding, not the lungs. They're actually very tiny. Look at their little lungs. And you know, almost disappear. Look at those little things. So again, the birds lack a diaphragm, so they don't change in size. The lungs don't. And they stick into the intercostal spaces of the ribs. So the air sacs, again, change size. Their movement of the body wall allows for them to change size. They have two collections of air trapping sacs, so one cranial and one caudal to the lung. It is essential for airflow, but perform no gas exchange. The arrangement of air sacs, airways, and lung results in a unidirectional airflow through the lungs. Thus, gas exchange occurs on both inspiration and expiration. So then we got into the alimentary tract. So their teeth are absent, 100%. There's no egg tooth. It's not a tooth. Crop, it is the closest. So the crop is not the stomach. It's where birds can put food, like they can eat it and store it. This is where they store food. So some species have this dilation of the esophagus, just cranial to the thoracic inlet. It provides, again, temporary storage, but no digestion of foodstuffs. So then we have the stomach. So they have one stomach, but it has two chambers. It has the proventriculus, which is glandular. It is cranial to the ventriculus, which has both glands and muscle. It produces acid and digestive enzymes and mixes them with the ingesta. And then we have the ventriculus, which is the gizzard, which is non-glandular. And it's used for chewing and grinding. It grinds ingesta with enzymes. So it takes basically the function of teeth. And then we have the small intestine. It has a duodenum. It forms a hairpin loop. It has also the jejunum and ileum. And I will finish this in just a second because I'm getting a phone call. Hi guys, I'm back. Sorry, Athena called me, so that's very important too. And I also had dinner. I finally got my Little Caesars that I've been wanting. We got thin crust though, but it was amazing either way. And I think I ended at the small intestine. Has the duodenum. It forms a hairpin loop, and it has the jejunum and the ileum, just like mammals. It has a liver and a liver and a liver. The liver actually surrounds the heart, since the lungs do not. And then the pancreas is inside the duodenum. It lies within the hairpin loop. And then we have the large intestine, which includes the ceca, plural is cecum, and it's present in many species. It's paired. It's variably developed among species who have it. It marks the junction of the small and large intestines. Its significant function is in water reabsorption and also some fermentation in some species. In the large ceca, it's significant lymphoid aggregation at the proximal cecal end, which is called the cecal tonsil. It extends between the ceca and the cloaca. Its far lesser function is in water absorption than in mammals. And then, of course, we have the cloaca, which I'm sure you've heard of. It is a common receptacle of digestion, urinary, and reproductive tracts. We have the cloacal bursa, which is an important immune structure communicating with the cloaca. And then we have urinary. We got into the kidney, which produces urine. It's elongated and tightly applied to the dorsal body wall and nestled into the bony pelvis. The caudal ends of both kidneys sometimes fuse right to left. So here's with your kidneys. And then urine. Birds excrete ammonia differently than mammals, as we all know. The avian urine is the whitish granular part of bird poop. In a cloacal deposit, the brown is the fecal, the white is the urate, which is the uric acid, and then there's a tiny bit of free fluid, which is the urine. We have the ureters, which are typical. It starts cranial with the renal parenchyma, becoming superficial in the middle division. It runs all the way to the cloaca. So birds don't have a urinary bladder. They just have a cloaca, which includes the coprodium, the uridium, and the proctodium. Their blood cells, they have erythrocytes, which are nucleated. They have white cells, which they also have various types of white cells, as in mammals. They have a heart that still has 4 chambers with the same names as ours. It's entirely separate, has entirely separate pulmonary and systemic circulations, and its location is on the midline, surrounded by the liver and not the lungs. Its atria are particularly thin-walled. and it's longer and relatively larger than in mammals. Then we have the renal support system, in addition to the hepatic portal system, where more blood through kidney at stressful times. So under parasympathetic drive, it delivers blood from the pelvic limbs to kidneys for processing. She skipped the immune system, but that's because she was trying to get through so much material. But we have the lymphatic organs, which are present. We have the primary lymphatic organs, which is the thymus and the bursa of Fabricius. Then we have the secondary lymphoid organs, which includes the spleen and bone marrow. Lymph nodes are absent in birds. They diffuse lymphoid tissue, waxing and waning aggregations of lymphoid cells develop an at-need along the GI tract and the respiratory tract. So then we got into endocrine. So major endocrine organs of mammals are present: the adrenals, the thyroid, the parathyroids, the pancreatic islets, the gonads, etc. And then we have the nervous system and special senses. So we have the brain, which includes the cerebral cortex, which is smooth. We have the optic lobes, which are large, and the olfactory lobes, which are tiny. Look at that little tiny brain. And then their eye is huge. It has a scleral ring, a ring of tiny bones within the white of the eye, the sclera, just posterior to the cornea. It helps to support the relatively large eye. It has a pectin, which is used for gas exchange. It's a cone-like structure in the caudal region of the eye, which is, again, assists with gas and nutrient exchange, and they have great color vision. The retina is well supplied with both cones and rods, conveying good color vision. The ear, there's no external ears present, so they have no pinna. The ear canal opens directly on the lateral surface of the head, and in some species, the opening is protected by a tuft of feathers. In others, it is not. And then we have the reproductive system for females. The female is a heterogamic gender, so it's designated ZW. In most species, only the left side of the tract persists into the definitive form. Typically, only the left ovary and oviduct developed. The oviduct is not the small, simple tube that is in mammals. It also undergoes size variation and can change from large to small depending if the bird is breeding or not. So they can shrink it when they're not and enlarge it when they are. It has various parts with various names, each producing part of the egg. Then individual parts of the oviduct are named. So we have the infundibulum, the magnum, and the isthmus, each of which has a particular function in producing specific portions of the soft parts of the egg. And then we have the Schlau gland, which is the uterus. And then we have the penultimate part of the tract, and it does as the name suggests. Then we have the terminal part of the reproductive tract, and it's very muscular. It pushes egg into the cloaca once it is delivered. And then we have the male. The male is homogamic. Their gender is designated ZZ. The testes also change in size depending if they are breeding or not. They are paired and internal. They have a duct system, essentially similar to mammals in terms of parts and names, and those open into the cloaca. So that was it for birds. I just needed to finish it. I hope you guys had a good day today. Long day tomorrow, like I said. Today was okay. I'm gonna hopefully get to go to bed early today. I'm gonna prep for tomorrow. I think I'm almost done with prep though. I'm gonna save some studying. I know I have an exam, but I need to catch up on sleep, and Athena's busy today, so tonight would be the night to do it. But I hope you guys, again, had a good day. Here's Sky Buddy for reference. Hello. I took him on a walk today. He was kind of not the best, but we're working on it. But I love you guys, and I will talk to you guys tomorrow.